Well, hello, I'm Dr. Tina Tan, and on behalf of CME Outfitters, I would like to invite you to today's educational activity entitled Equitable Prenatal Care, Preparing for Future Maternal RSV Vaccinations. Today's program is supported by an educational grant from Pfizer Incorporated. Today's program is brought to you by CME Outfitters, who's an award-winning accredited provider of continuing education for clinicians worldwide. So once again, I'm Dr. Tina Tan. I'm an infectious disease physician at Ann and Robert H. Lurie Children's Hospital of Chicago and a professor of pediatrics at the Feinberg School of Medicine of Northwestern University. And I'm also president-elect of the board of directors of the Infectious Disease Society of America. And I'm absolutely delighted to be joined today by my distinguished panel, who I will ask to introduce themselves.
My name is Kevin Alt. I am professor and chair in the Department of Obstetrics and Gynecology at Western Michigan University, Homer Strecker MD School of Medicine in Kalamazoo, Michigan. I've also played a role in the approval of this vaccine, and we're going to hear about the FDA, the American College of OBGYN, and the CDC recommendations a little bit later in the presentation.
Thank you. And I'm Latasha Rouse. I am a certified doula and a patient engagement consultant. I'm owner of Birth Sisters Doula Services in Raleigh, North Carolina. I am the mother of triplets that were born at 26 weeks, 6 days, and did receive the neonatal or the infant RSV vaccine. So I have so glad to be here for this conversation today.
So as you can see, we've assembled a very diverse and lovely panel today. So let's jump right in and begin our discussion by evaluating the latest data for RSV maternal vaccination, including protection for infants from severe RSV infections. And specifically, we will examine maternal RSV vaccination as part of prenatal care, what you should know to best advise your patients. But before we get started, we want to get our audience involved with a quick audience response question. And so this question is, which of the following agents is an FDA-approved RSV vaccination for pregnant people? Is it the RSV pre-F vaccine Abrysvo, the RSV pre-F3 vaccine Arexvy, Nirsevimab, which is Beyfortus, or I don't know? So thank you all for answering. We'll come back to that question and discuss the correct answers later. So before we get started, I just want to go over a very important note. As you may have noticed in our question just now, our activity today will include both generic and brand names of all agents used for both clarity as well as consistency. So now, Dr. Alt, as you mentioned, you've been involved in the RSV clinical trials, and therefore I'd like to have you share with us what we currently know regarding RSV in infants and young children.
Well, despite being involved in the trials, I'm not sure I really appreciated the burden of disease due to RSV in the first few months of life until I started digging into this topic a little more. I am an OBGYN. I too am a parent of a premature baby, and she received palivizumab many years ago after she graduated from the NICU. But this slide tells us that RSV is a leading cause of hospitalizations during the first year of life. And I'm sure we have some pediatricians in the group. I'm sure many of you remember spending January and February in the inpatient ward, maybe when you were a resident, taking care of these infants. But and I like the bolding here. It's the leading cause of hospitalizations in the first year of life, bar none. So I think that's a very important point, and that's what we're trying to prevent with these vaccines. This has been a long road to get an RSV vaccine approved. Some of you may have seen Sean O'Leary, who's a pediatrician at the University of Colorado, quoted in the news, and he talks about how long this has been going on. Of course, we had a formalin inactivated vaccine back in the 1960s. That's the way we make flu vaccine and inactivated polio vaccine and some of those vaccines that date back to the middle of the last century. However, it was a failure. It caused immunopathology and it was shelved for a long, long time. Eventually, there was some work done at the NIH with Dr. Barney Graham that identified surface proteins, particularly the prefusion F protein as a vaccine target. The same group of researchers also worked on surface proteins for COVID, for coronaviruses, and that led to phase 3 trials for adults and pregnant women. As you can see in this timeline, this is such a wonderful timeline. I'm going to steal it for any future talks that I give on this topic. And I'm going to let Dr. Tan talk about this question a little bit.
Well, thank you, Dr. Alt. So I'm just going to jump right on in. So this question is, one of your patients is presenting to see you at the community health clinic where you practice. She's 35 weeks pregnant, and she's not really interested in getting the vaccines that should be given during pregnancy. She, however, is open to discussion and asks you why it would be beneficial for her to receive the RSV pre-F vaccine Abrysvo now. Which answer is accurate and individualized for this patient? Is it that the vaccine is only moderately effective to reduce RSV hospitalization as compared to nirsevimab or Beyfortus for neonates, but is safe and well tolerated? Is it that the vaccine was found to significantly reduce RSV-related hospitalization risks and allow you to provide immunity to your infant from the time of birth? 3 is the vaccine found to significantly reduce the risk of babies acquiring RSV from the time of birth within the hospital setting only? Was the vaccine found to reduce the baby's risk of hospitalization or severe RSV even further when concurrently given with nirsevimab or Beyfortus to the infant after birth? Or I don't know. So I want to thank everybody for answering, and we'll come back to that question a little bit later and discuss the correct answer. So audience, thank you again for answering that question. And Dr. Alt, can you share with us the importance of maternal vaccination?
Well, this is something we all learned in medical school and has continues to be practical. There are several vaccines that protect newborns, including the vaccine we're talking about tonight through this mechanism. There's passage of maternal immunoglobulin, IgG, from the maternal circulation across the placenta by active transport into the fetal circulation. And the IgG that a newborn has when it's born with, this is the mechanism that it has to protect itself against some of these infections during the newborn period. The breast is not shown here, but it's some of the same mechanisms plus IgA antibodies. There are plasma cells resident in the breast that produce lots of IgG and IgA and provide protection through that route as well. Well, I'm not able to advance here, so let's see. Aha. Small technical difficulty, I apologize for this. So this is the answer to the question you just saw a few minutes ago, and it's also the results from the New England Journal of Medicine publication from a few months ago. We actually used this for Journal Club for the OBGYN residents, but it's the classic placebo-controlled blinded trial. And one of the outcomes is medically attended severe RSV-associated lower respiratory tract infection. And the blue line here is the placebo group, and the goldish line there is the vaccinated group. And as you can see, those lines diverge very quickly within the first few months of life, and that protection is sustained for 180 days and effective for hospitalization. And so, this is very good news as far as protection goes, and offers protection against hospitalization and severe disease in this vulnerable first few months of life. This vaccine was found to be safe, as you might imagine, from a vaccine versus placebo trial, that the most common adverse events were related to injection site and were more common than placebo as far as injection site pain, muscle pain, and headache was a little bit more common. So not anything unusual than you'd see in most vaccine trials versus saline placebo. There were no serious adverse events related to the vaccine in this trial. Here's that alphabet soup that I mentioned a little bit before, and all these recommendations have just been made in the past few months. So the FDA approved the vaccine after the hearing in May that I was involved with over the summer. Then there was a CDC meeting in mid-September, if I remember correctly, of the Advisory Committee on Immunization Practices. And then very quickly after that, the CDC and the American College of Obstetricians and Gynecologists made these recommendations for this vaccine. So, and I am going to turn it over after that discussion of the clinical recommendations to Dr. Tan.
Thank you so much. And I think that's really important information that you just showed with regards to the effectiveness as well as the safety of this vaccine, and the fact that all the major organizations recommend this vaccine for pregnant women. So why don't we go back and address the first question that we looked at, which is, which of the following agents is an FDA-approved RSV vaccination for pregnant people? And if everybody wants to put in their responses, then we'll see how we do. Oh my gosh, you guys did great. I mean, this basically shows that, you know, we're able to learn, we're all learning, and that's fantastic. But, you know, as always, there's still much more to learn, but I think that's fantastic. If you look at the correct answer, which is A, and, you know, there was a 30% response pre-test and a 92% response post-test. So I think that's absolutely fabulous. So let's now discuss how to assess the impact of RSV disease on infants, on pregnant individuals, and the healthcare system at large, particularly among underserved populations. And in particular, we're now going to discuss disparities in prenatal care as this relates to RSV for infants, pregnant individuals, and the underserved community. So as Dr. Auld pointed out, RSV is one of the most common causes of acute respiratory tract infection in people of all ages. And RSV here in the US typically circulates in the fall, the winter, and spring. So that usually encompasses the beginning of October to the end of March. And each year in the US, RSV leads to approximately 2.1 million outpatient non-hospitalization visits among children younger than 5 years of age, with the vast majority of the cases of infection occurring in full-term, healthy infants under 6 months of age. And this can also cause fairly severe infection in older individuals, with up to 1.4 million outpatient visits among adults 65 years of age and older. It can result in up to 80,000 hospitalizations among children younger than 5 years of age, 160,000 hospitalizations among adults 65 years of age and older. And notice the number of deaths that we see in this older population: 10,000 deaths among adults 65 years of age and older, and around 300 deaths a year in children younger than 5 years of age. If you look at the risk factors for severe RSV illness, we can see that premature birth, as Dr. Auld and Ms. Rouse both pointed out, they had premature infants that were protected with RSV monoclonal antibody. But notice that very young infants, especially those under 6 months of age, especially those in the first 2 to 3 months of age, are at very high risk for having severe RSV disease if they get infected. Also notice that American Indian and Alaskan Native infants and children are at particularly high risk for severe RSV disease. Anyone living in crowded living conditions, any person with chronic lung, chronic heart, and anyone with a weakened immune system, all are at increased risk for severe RSV illness, as well as those individuals that have neuromuscular disorders. And if you look at the economic impact of RSV, it is massive. While RSV hospitalization of premature infants can cost up to 5.6 times that of a full-term infant, full-term infants account for 82% of the RSV hospitalizations and 70% of the RSV hospitalization costs. I think what's even more eye-opening is that infants that are insured through Medicaid were found to be 91% more likely than commercially insured infants to be hospitalized for RSV in their first year of life. And medically attended RSV care in infants costs on an annual basis over $709 million. And if you look at the amount per birth, you can see that it's $187 for overall births, but it's $227 per publicly funded birth. So you can see that there is a health disparity that is occurring here. We look at the RSV hospitalizations that were seen with our last RSV surge, which was at the end of 2022 and the beginning of 2023, we know that the RSV hospitalization rates at the peak of the surge were about 5 per 100,000, which is about 4 times what was seen pre-pandemic. There were 3 to 4 times the number of infants and children being hospitalized compared to prior years, with an increased number of older children requiring hospitalization. And the other thing, which is important to point out, is that there were up to 2 times the number of adults, including pregnant women, being hospitalized compared to prior years during this last RSV surge. Now, this is a very interesting study that looked at RSV cases in children under 5 years of age here in the US from 2010 to 2023, and really points out that it is the younger infant population that accounts for the majority of cases. So on the left side of the slide there, it shows the seasonal pattern for first-time RSV infection incidence rates in young children ages 0 to 5 years. And on the right side of the slide there, it shows the seasonal pattern for infants between 0 and 1 year of age. And you can see that when you look at the graphs there, there's a significantly higher amount of disease being seen in the younger infant population. What's also very interesting is to look at in whom the infections are occurring in. And here, what they looked at was that they broke the 0 to 5 year old population down into those that were white, Hispanic, and Black. And what they found in the 2022-2023 surge was that the peak incidence rate of RSV was 2 to 3 times higher in Black and Hispanic infants and children compared to white infants and children. So again, really showing a health disparity. What we know is that RSV among American Indians and Alaska Native children also occurs more frequently. And this was a study that was an active facility-based surveillance for acute respiratory infections among hospitalized American Indian and Alaska Native children under 5 years of age that were living on various reservations in Arizona, in Anchorage, and in the Yukon Delta region of Alaska. And what they basically found in the study is that Alaskan Native and American Indian children had hospitalization rates that ranged anywhere from 2 to 7 times higher than infants of other ethnicities. And when they looked further into these kids' living conditions, they basically found that the majority of the infants were living under very crowded living conditions, with 35% or more of the homes not having any running water. So you can see that these individuals are living in rural areas with a lot of other people and in circumstances where access to healthcare is much less available than in other regions of the United States. But again, it really points out that these children are at much higher risk for hospitalization and severe complications when they get RSV disease. So the other thing that is really important to recognize is the recommendations by the CDC relevant to pregnant women and infants with regards to vaccination and monoclonal antibody. And the CDC recommends that either maternal RSV pre-F, the Abrysvo vaccine, be received during pregnancy, or nirsevimab or Beyfortus be given to the infant after birth to prevent RSV-associated lower respiratory tract infection. But both of these are not needed for the vast majority of infants. You look at the RSV immunizations that are available. The one that we're giving pregnant women is the RSV pre-F Abrysvo vaccine, which is an unadjuvanted bivalent recombinant prefusion F protein vaccine given as a single dose. And then the nirsevimab or Beyfortus is the longer duration monoclonal antibody that's indicated for neonates and infants under 8 months of age that are born during or entering their first RSV season, or to children who remain vulnerable to severe RSV disease through their second RSV season. So let's go back to the question that was asked before. This is the question where one of your patients is presenting to see you at the community health center where you practice. She's 35 weeks pregnant and is not really interested in getting the vaccines that are recommended during pregnancy. She is, however, open to discussion and asks you why it would be beneficial for her to receive the RSV pre-F vaccine Abrysvo now. So which answer is accurate and individualized for this patient? And you guys can basically put in your responses, and then we'll see how we do. So the correct answer is B, and you guys did a fabulous job. You can see there that pre-test 49%, post-test over 75%. So it really highlights that we are learning something during this particular session, and we have more things to learn. But I think this is really, really impressive. So let's pause to answer a question before we moved on. And the question here is, which of the following is the most appropriate way to overcome barriers to maternal RSV vaccination in practice? Is it to ensure the patient that there is nothing to fear regarding vaccination? To explain based on health literacy of the patient what the vaccines are and why they're important to receive? Give the same standardized information about vaccines to all patients, or require vaccination discussions for future appointments? Excellent. You guys really understand the importance of health literacy of the patient, what the vaccines are, and why they're important to receive. So great job, everyone. Great job. So some key takeaway points from what we've just learned is that we know that RSV can cause serious illness in infants, children, and adults, with those under 2 years of age, and then the older adults, 65 years of age and older, being at the highest risk. And vaccination is the best preventative method of protecting individuals from developing severe RSV lower respiratory tract disease, complications, hospitalization, and death. And an RSV vaccination for moms and a maternal antibody for infants, unfortunately, there is a limited supply of antibody. The 100 milligram dose currently are available, and they are the best methods of providing protection to infants, children, pregnant women, and older adults against RSV disease. So now we're going to delve into actionable strategies to address real-world implementation-related challenges of maternal RSV vaccination, with a focus on guidelines and tools to overcome barriers to access. And Ms. Latasha Rouse will now provide us with some insight into how we, as providers, can navigate implementation-related challenges with maternal RSV vaccination. Now, Ms. Rouse, not all of our audience may be familiar with what a birth doula does. So can you now share with us what a birth doula does and your story on how you became a birth doula?
Absolutely. So the definition of a birth doula is someone who is professionally trained on continuous physical support, emotional support, and informational support of a mother before, during, and after childbirth, to help her to achieve the highest and most satisfying experience possible. And so I became a doula after working on several initiatives in my state and nationally, and learning about the gaps that exist in healthcare and how information is oftentimes not given to patients and families, including my own experience, in a way that I could understand it. And I knew how to ask the questions. I usually got home and I had questions that I couldn't ask during the appointment. Things happen so quickly. Helping people to prepare for those questions in advance. This is probably what's going to happen. You need to think about these appointments coming up. And here's where you get good information is a lot of the prenatal work that happens when you're a doula. And that's the part that I love the most. People think it's the birth part, but getting people ready and helping them giving them the information so that they're empowered is something that I love. And so as I spoke about my experience of having my triplets at 26 weeks, 6 days, vaccines come up often, and we have a lot of discussion about why I made decisions I made for my family because of the experience of having children in the NICU. It being able to explain what the experience is like and thinking about the logistics of a hospitalization, thinking about the logistics of a one child or maybe two being in a hospital is a very different thing. And that's not something usually that you hear from a clinician. You don't hear that. You hear about higher rates, but what does that look like? You know, how expensive is that? Who's handling childcare? What support do you need? That's a lot for a family to take on. And so I spend a lot of time helping people to understand that and helping them to get the information that they need. I'm going to share some tools that I use with families to help them get information, to help them to be a part of the shared decision making, and also learning what some of those questions and challenges and barriers can be for them so that you can potentially use these in your work. So it's important to start the conversations early. And it can be something as simple as starting to ask about, are you taking childbirth education classes? What are some of the areas of interest? So this is during the appointment. What have you been interested in? Because people key in on different pieces of the information. Sometimes it's breastfeeding, sometimes it's, infant care, but being able to take some of those key points and tie that into thinking about talking about the vaccine. So you can ask about the vaccine at that point and tie it to some of those key points of interest that they have. And then being able to help them to recognize that they can always come to you for information. Sometimes it feels like in healthcare, people are so busy and they don't have time to answer, your questions. So being able to say, you can come to me for information. I may have someone that might be a great reference or support, and they can speak to you about it. It may be me, but I want you to know that you can get information is key. And these early conversations are really helpful because otherwise you have people who are on the internet trying to find information. And the internet is very confusing for patients and families. And it creates a lot of frustration because they're trying to find information, but they don't know where to look. And you can't tell what's good information on TikTok. So being able to know that they have a place to come for information is important.
So Ms. Rouse, what happens if you're bringing up the maternal RSV vaccine to one of your patients and the patient is just adamantly against receiving it? How do you bring it up again?
So for that, I let it go for a little while. I'm in communication with my clients every single week at minimum, right? So this conversation will get picked back up in a couple of weeks. You got an appointment coming up. They're probably going to ask you about it. Have you gotten any information from the sources that I gave you that were helpful to you? Where do you stand now? I just wanted to check in and see where you are because I know you were still working on getting information. And I would put it in a way that you're still getting information, even though knowing that they were pretty adamant about it. And usually they will have other questions. And so once you start to give them that additional information and you start to understand what they have probably been told and where they're getting their information from, you can then provide them with that redirect. But that can help as we approach it as you're still getting information.
And what benefits of the maternal RSV vaccine seem to be the most motivating to mothers to get it who are considering getting it?
Usually it is the protection for the baby. And once people understand the protection for the baby, that is something that is really like the big motivator. It becomes the baby. That's how people are usually motivated when they're pregnant. They don't think as much about themselves unless they have something special or something that's going on outside of the norm. They're thinking about the baby. Yeah, great questions. So this tool, this brain tool, is a tool that I often use throughout the journey in healthcare for pregnant people because they have not had the experience most of the time when they're pregnant. This is their first time even going to a hospital a lot of times. So I introduced this tool very early, and I have them use it as they start to make decisions and start to learn about information and when interventions will be introduced. And it's called the brain tool. And it just says, what are some of the benefits? What are some of the risks, the alternatives? Mom, what does your intuition say? What happens if we don't do this now or we don't do this at all, right? So being able to get that information, that gives you all the information that you can possibly need to kind of learn more about it. And in this, what happens if we don't do this now or not at all, being able to describe the experience of what a hospitalization, what things people have to think about if that were to happen, and how likely a hospitalization is for a baby who does come down with RSV, is a part of that. What happens now if we don't do it right now? But going through this gives them a tool that they can use throughout their healthcare journey. And it gives them a way to make sure that they've asked the questions and they've gotten them all in. So now that we've kind of gone through this, now, is there anything else? And you're empowering them to get the information that they need. Okay. And then finally, motivational interviewing is something that a lot of people do speak about, but they are not necessarily using often because it is something that gets tucked away, but it's very powerful in these scenarios. We've heard people already state, you want to understand what some of the barriers are. So using motivational interviewing, this rule helps you to move through the conversation. So you want to resist telling them what to do. The recommendation is that I recommend that you would get this, but not, I'm going to give you're going to do this in practice. People don't necessarily like that. And then thinking about, understanding their motivation. What are some of the values that they have? What are some of the needs and motivations? Finding out what some of those are and what are those barriers. We've had that come up several times. So that's very important in motivational interviewing. And then you want to be able to listen with empathy. People are making decisions based on the information that they have at the time and what their values are. That can change. The way that you handle the conversation and having empathy in a conversation can mean a lot to how people respond and what they decide. So that is something that I often do. There are a lot of times when people make decisions I don't necessarily agree with, but handling them with empathy has always shown to help in those scenarios. And then empowering them, helping them to work to set those goals, identify what some of the techniques to overcoming the barriers. Maybe they are looking at this from a lens that you are, the barrier. You are the barrier because it's coming from a doctor. Okay. So if there are childbirth education classes going on and that those are happening, being able to connect them to resources to get more information, even having some of those childbirth educators learn some of this information can be helpful as they are working to empower and educate the patients and families. So all of those are very good steps to get through motivational interviewing to help to make sure that this is not something that people have a knee-jerk reaction to.
Mhm.
And now I'm going to look at these, Dr. Tan and Dr. All. These tools that I use, these are the tools that I use. Are there other tools that you use in your work?
Well, I mean, you brought up some really important points. And I think when you look at motivational interviewing, what I found the most useful is listening with empathy and understanding where a person is coming from. Because many people will tell you that, a lot of times when people talk to them, they say, you have to do this. And they don't want to listen to them with regards to why they have some reservations about doing it.
Right.
So it really is very, very useful when you can listen to them and understand where they're coming from and seeing it from their lens so that you can provide them with the information to help them better make a decision.
Can I ask a question? It's going to lead to an answer to the question you just said. So, Ms. Rouse, if somebody has adequate prenatal care and it's the middle of their pregnancy, so 20 weeks, do you talk to them about what's coming up at the next couple of visits, because they're spaced 3 or 4 weeks apart? And what do you tell them about those? There's a fair amount that goes on the next 2 or 3 visits. What do you tell your clients about that?
So I tell them about all the visits that are coming up for sure, prepare them for what questions that they already had going into these about what they're feeling and experiencing, if there have been anything persistent happening. And then if there will be these conversations and they haven't had it yet, I will say this is probably going to be a conversation that's coming up. So vaccines or any other thing. So I do prepare them for those visits. And usually when they are prepared and they go in prepared, I find that they do make better decisions. They don't feel rushed. They don't feel stressed during the visits. And they've had some time to think about what might be coming. So that's important to help people to know what's coming at the next visits. And that doesn't necessarily have to be a doula. That could be something that people have like on a sheet that says, here are the visits that are coming. And these are, some of the topics that you might discuss. That could be something that people prepare. And that way these conversations start early.
I mean, one of the recommendations about vaccination during pregnancy is about a decade old, the pertussis or the Tdap booster. And, we purposely, we being the CDC and ACOG, purposely link that to the diabetes screening that we do about 24 to 28 weeks. And this one's a little later. So while you were talking about your methods, I thought, well, you can prep the patient for what's going to happen after 28 weeks. There's a whole series of things there that checking for anemia, checking for diabetes, and giving the pertussis booster to prevent whooping cough in the newborn period. There's a whole series of things that lead up to giving this vaccine.
Yes, absolutely.
Yeah.
And those are the road to people understanding. All of these tie together. Yes.
Well, thank you both for such a stimulating discussion. I want to offer some SMART goals, which are specific action items that all of us can use immediately in our practices. And these SMART goals stand for specific, measurable, attainable, relevant, and timely goals. And these include evaluating the available phase 3 clinical trial data for the RSV vaccines, particularly from the Matisse trial behind the FDA approval of the only maternal RSV vaccine, Abrysvo, making a strong recommendation for eligible pregnant women between 32 and 36 weeks of pregnancy to receive the maternal RSV vaccine, and using techniques as we just discussed, such as motivational interviewing, to encourage the pregnant patients to receive the recommended vaccines that have been shown to improve health outcome. And I think that is really important because this is a way to level the playing field, because we know that there are certain individuals that, for a variety of reasons are at increased risk for RSV complications and their infants are at increased risk for RSV complications and hospitalizations. So this is a way to get everyone of every ethnicity vaccinated, so that we're able to provide protection for everyone. And so there are a couple of questions here. One is there a certain gestational age that is best to get the vaccine? And can they get it with Tdap vaccine, flu vaccine, or COVID booster? And
Yes. Can you say yes to all those? Is that,
yes,
is that
yes
one of
to
my
all
options?
those. Gestational age is 32 to 36 weeks. And Dr. Altz?
Most of us have, pre-existing immunity to flu and pertussis and RSV. So yeah, again, thinking back to when you learned this a long time ago, you get a memory response and antibodies that take about 2 weeks. And so if that time frame is great, you can give pertussis vaccine, you can give flu, you can give COVID. It's just a matter of how much arm space you have that you want to get, how many you want to give. So it would be nice to have some co-administration data. We do have that for flu and Tdap during pregnancy, but of course, with a brand new vaccine, it's going to be hard to find those data.
Yeah. And are there any reported Guillain-Barré syndrome among pregnant patients or their infants after vaccination? And this is compared to placebo.
No, and there were, none of us are adult ID people, but there were in the adult trials that was a concern, but there weren't in the pregnancy trials.
Right, and there weren't any in the infants of the moms that
right.
received
I didn't answer that. So,
the other question is, do you recommend the vaccine out of RSV season?
So my thinking about this changed and over the period of hearing this data. So again, keeping in mind that I came into this as an obstetrician, RSV season is so compacted that there's not a lot of benefit to going outside that season, and it becomes horribly cost ineffective. So when I first heard about this vaccine, I thought, let's just give it all year round so don't miss anybody. But then after seeing, the data about when, newborns get RSV, I realized that I was wrong. So I'm willing to go back and change my mind. It's really just this period of time that we're going to give it. And of course, if we get a decent supply of nirsevimab, we can eventually give that to older infants and maybe patch that, again, thinking about what might be happening in 2024. So.
And why isn't the vaccine recommended to be given earlier than 32 weeks gestation?
So we had a slide about that and we ended up taking it out because we were afraid we were going to go over. So the clinical trials were done down to 24 weeks. The Matisse trial was done down to 24 weeks, and there was a signal for premature birth. There was an excess of premature birth in the people that received the vaccine, and we could spend another 10 minutes talking about that. So I don't want to spend too much time, but if you're really interested, you can listen to the FDA recording of this that's on YouTube. So, but basically, if you gave the vaccine after 32 weeks, there were no excessive preterm births. And so that was where the line was drawn. Paul Offit actually did he has a blog that he does and did a nice blog about that a week or two ago, if you would like to see a much shorter explanation of what we talked about at the FDA.
Yeah. There's a question here about how they can keep track of patients that are supposed to receive the RSV vaccine in the electronic health record. So is there like a reminder that pops up?
You have a lot more job titles than I do. I would have asked you this question with your administrative question, so I probably would have punted this one. This is going to be, coordination of care is something we do not do well in the American healthcare system, and a fair number of obstetrical care providers, midwives, and OBGYNs and family doctors work in multi-specialty health systems And so I think that's an IT question if you're in that system. But of course, in a community like Kalamazoo, we have some people that are employed by one of the healthcare systems or by the other healthcare system, or independent from both healthcare
Right.
systems. So, I think,
It's
working
going to
on a
depend
microcosm
on
of the
your
system.
EHR, and it's going to depend on if you can get that customization done. That's really, yeah.
Yeah. And there was a question here regarding something that I talked about regarding the increase in RSV in Black and Hispanic infants and the type of insurance that they had. And the vast majority of those individuals had public insurance or no insurance at all compared to private insurance. So there's another question here about guidelines for receiving the RSV vaccine after receiving COVID or after having COVID.
I don't know that there's any particular prohibition on that. Are we talking about pregnant
Yes.
people or
No,
the?
this is pregnant
Okay.
people, and there, at least from my understanding, there is no timing or other precaution that needs to be taken. I mean, these individuals can get this vaccine.
Right. There are general considerations, about vaccination. Don't vaccinate people when they're critically ill with COVID
Right.
or
Correct.
symptomatic. But other than that, I don't know that there are prohibitions.
Right.
Precautions, I guess, is probably a better word than prohibitions.
So there's a question here about whether a pregnant patient would be able to receive vaccination after 36 weeks gestation.
It's a matter of timing, and a fair number of people, including the people in the Matisse trial, deliver at 38 to 39 weeks. And so if you start getting past 37 and 0, you don't get that 2-week buffer to
Right.
make maternal antibodies. And then you end up, in a situation where you were trying to get nirsevimab for that baby. And so you're in a, you've had a good intervention that is not so good because of the timing.
Yeah, absolutely. And at least this season, there is an issue with the 100 milligram dose of nirsevimab in that there's a supply shortage. So this season, it's probably going to be more important if we can get more of the pregnant women vaccinated so that they can give some protection to their young infants. So there's a question here about when we talk about RSV season, is it the time the baby is born or simply when the woman is at 32 to 36 weeks entering RSV season?
There are some very eloquent diagrams in the CDC's discussion of this, but basically, you have 3 to 6 months of risk for the newborn, and you have a month or two of pregnancy left, and so that gets you to September 1st to January 31st for that time frame. So, and a lot of that assumes you're going to have a term pregnancy, but again, the median age of the people in the Matisse trial was 39 weeks, if I remember correctly. And that's probably the median in your community as well. So,
Yep. Well, that's all we have time for today. And I would really like to thank Dr. Alt and Ms. Rouse for an absolutely stimulating discussion, and to thank you, our audience, for joining us today. You can find the slides from this activity in the course guide under the resources tab of this program. And don't forget to visit the Infectious Diseases Hub at cmeoutfitters.com for more free resources and education for healthcare professionals and patients. And to everyone, please be safe, take care, and thank you for all the life-saving work that you do.